Assalamu alaikum wa rahmatullah. My name is Mohammed Almekhlafi, and I'll be talking to you today about secondary prevention of large artery disease. I'd like to thank the organizing committee for this invitation. These are my disclosures. None of them are relevant to this talk. So today I'll try to cover some background about large artery disease and in particular carotid artery disease, some classification and emerging concepts in this disease, and we'll focus on the management aspects. So large artery disease accounts for almost a fourth of all cases of acute ischemic stroke. Large artery disease entity include aortic arch, extracranial carotid and vertebral artery disease, as well as intracranial atherosclerotic disease. And as I said, for the purpose of this presentation and common things being common, I'll be focusing mostly on carotid artery disease and some of the emerging concepts. And carotid artery disease, as this audience know, is a narrowing of the carotid artery, almost always in the majority of cases caused by atherosclerotic plaque, but there are other entities that may also produce narrowing of the carotid artery. And it can be asymptomatic, or it can present with transient neurological symptoms, TIA, or in some cases with stroke. Symptomatic cases could present with the retinal events, and in these circumstances, patient described the classical curtain-like loss of vision, monocular, could be painless or painful. And if we're lucky, sometimes we clinch the diagnosis at the bedside by looking at the retina, as we can see in this picture, seeing a Hollenhorst plaque in the retina. And so amaurosis fugax is confirmed in that entity. However, it can present also with weakness, with motor impairment, and classically the cortical hand syndrome, in which the patient described sudden acute weakness and loss of power in the hand that could be transient or permanent, depending, and it can be sometimes hard to differentiate from peripheral neurological causes. One of the peculiar presentation of a carotid artery, especially when it's non-atherosclerotic or non-stenotic disease, is the recurrent ipsihemispheric stroke. And so patient present with large vessel occlusion or sometimes that TIA, and then present with another TIA in the same territory, and that would force us to look closely to the carotid artery. And some of the concepts that I'll be talking about today emerge from this understanding that there is a recurrent ipsihemispheric ischemic events, ipsilateral to either less than 50% carotid stenosis or a carotid web. And so etiological classification of a carotid artery disease include atherosclerotic, which can be further classified into non-stenotic, and the symptomatic non-stenotic carotid disease, or SYNC, has emerged in recent years as accounting to about, or noted in about 20% of patients with acute stroke who have otherwise no explanation for their strokes. In this study of describing that the thickness of more than 4 millimeters ipsilateral to a stroke was found to in about 20%, while 5% on the contralateral side, while plaques of a thickness more than 3 millimeters was present ipsilateral to stroke in over a third of cases, compared to only 15% in contralateral. And therefore, these differences were significant, indicating that these carotid plaques could have more than an association, but probably or potentially an etiological explanation to the ipsilateral stroke. And when we take this carotid non-stenotic disease into account, the etiological classification of stroke can be shifted. In this paper here, we show that patients who initially were classified as cardioembolic, about 20% of them will be shifted to having multiple etiology, cardioembolic plus symptomatic non-stenotic carotid disease in 20% of the patient, while about, again, 20.8% of patients with ESIS will be shifted to large artery disease if we classified the presence of ipsilateral sink as the possible underlying etiology. And so this concept of symptomatic non-stenotic carotid disease is emerging. There are a number of markers to indicate the high-risk plaques, for example, using MRI or other imaging modality, but it is a concept that is in development, and up till now, the management hasn't been kind of changed based on the presence of sink versus not. However, it is something to be looking for. Patients with severe carotid disease, the 50 to 90% or more stenosis are the kind of guardian variety of carotid disease. I'll be talking about him a little bit later. However, I just wanted to touch on the carotid neuro-occlusion, which is an entity of the severe carotid disease. However, there is, in addition to the stenosis, distal collapse of the carotid artery, as we can see in this image, that the caliber of the carotid artery is much smaller and collapsed to some extent distal to the stenosis. And those patient population are known to have a much benign history in comparison to the severe carotid disease without distal collapse, as we can see from this graph from the NACIT trial. Although patients who have carotid neuro-occlusion did benefit from endotrechtomy, the benefit was modest in comparison to patients without distal occlusion. And patients who had full collapse, there were only a few, but nonetheless, none of them had any recurrent stroke on medical treatment or on post-endotrechtomy. And finally, another atherosclerotic entity is carotid occlusion, where there is complete occlusion of the carotid artery without any filling. And this could be in the setting of an acute stroke, which is called the tandem occlusion, if there is extracranial as well as intracranial carotid occlusions. And those patients population are outside of the scope of this talk that focus on secondary prevention. However, they are important to recognize. The more likely scenario is patients with carotid occlusion presenting with either TIA or stroke. And in those cases, first, we want to confirm that the carotid is truly occluded. And this could include either doing two different modalities. If a patient had a carotid ultrasound, then we'll confirm with the CT angiogram or vice versa. And then to confirm that the carotid remains occluded by repeating the imaging with CTA or carotid ultrasound in about 6 weeks up to 3 months. There are ways that we can stratify the risk of carotid occlusion by doing a transcranial Doppler, looking for microemboli, and patients who have carotid occlusion with noticeable microemboli on the same in the same territory could benefit potentially from short-term anticoagulation. And this is kind of anecdotal evidence without any confirmed prospective data. And finally, we follow them, as I said, by repeat imaging to ensure that the carotid remains occluded. If the carotid opens up at 6 weeks or so, then those patients will be managed as if they are, for example, severe carotid stenosis and require revascularization. The other entity with asymptomatic carotid occlusion, for example, if a patient was going for CABG and they happen to have a carotid ultrasound which shows ipsilateral or unilateral carotid occlusion, in those cases, usually medical treatment is all that is required with control of blood pressure, vascular risk factors, lipid profile, and smoking cessation, etc. The non-atherosclerotic disease, I take few minutes just to touch upon some of the emerging entities. Carotid dissection is one of those well-described features in which there is an intimal flap with wall hematoma, as we can see here on MRI, or pathologically, we can see here that the lumen is compressed by the blood products that are accumulating in the wall, leading to either severe stenosis or occlusion of the carotid artery. Those patients has distinctive appearance on either non-invasive or invasive imaging, as we can see here with the flame-shaped tapering of the carotid artery. On the middle picture, we can see the intimal flap, and in some cases, we see pseudoaneurysmal formation indicating a healed dissection. The management of those patient population has been debated between anticoagulation versus antiplatelet therapy, but for extracranial or cervical carotid dissection, the CADIS trial, which was published recently, compared patients who received antiplatelet therapy versus anticoagulation. With antiplatelet therapy, there was a myriad of modalities between single and multiple antiplatelet therapy, while anticoagulation was mostly with heparin and then warfarin versus 10% with warfarin alone. But basically, this study showed that about 2% of patients on antiplatelet had ipsilateral recurrent stroke or death compared to 1%, which was not statistically significant. And therefore, those patients are usually managed by antiplatelet therapy in the most cases. Current guidelines support this, that those patients, antithrombotic therapy for at least 3 months is indicated for secondary prevention. If the patient had they have carotid disease that are resulted in recurrent event in spite of maximum medical treatment, then revascularization, mostly with stenting, I think, but it's reasonable for endotrechtomy in selected cases to be considered. Carotid webs is an emerging new concept that I wanted to highlight in this slide and bring to your attention. So this form is thought to represent an intimal variety of fibromuscular dysplasia in which there is a fibrous band into the lumen of the carotid artery. Those patients' population or this entity is noted in up to 1/3 of patients with cryptogenic stroke, less than 60%, more often in women of Black racial identity. And within a 2-year follow-up in this study from the Mr. Clean registry, 17% of patients with carotid web had recurrent strokes in comparison to 3% of patients without carotid webs. And so until now, current guidelines recommend antiplatelet therapy. However, in patients with recurrent events, despite maximum medical treatment, stenting or endotrechtomy should be considered. And again, this is one of the causes that are of recurrent large vessel occlusion, especially in young people, or recurrent strokes in general, that can be missed if the operators on ultrasound or the interpreter of the CT angiogram wasn't specifically looking for the carotid bifurcation for such changes. Fibromuscular dysplasia is a non-atherosclerotic, non-inflammatory entity that can present with hypertension in young people, especially women, with a classical appearance of the vessels with string of beads that can affect essentially any artery in the body, but mostly in the cerebral arteries, presenting with either aneurysmal formation, cervical dissections, or focal stenosis, especially in the renal arteries. There are 3 types of FMD, mostly asymptomatic, and medical treatment if those patients present, for example, with dissection. If there is recurrent events or severe stenosis, then stenting is probably preferred over surgery for those patient population, but the literature is fairly limited in this area. Radiation-induced enhanced or accelerated atherosclerotic disease and stenosis can be seen, could be unilateral or bilateral. Those patients are mostly, if symptomatic, with severe stenosis referred for stenting, given the complexity of the surgery with scarring post-radiation. Diagnosis of carotid disease, there are a number of entities. Usually nowadays we rely on non-invasive imaging with CT angiography as the preferred modality, Doppler ultrasound, MR angiography, but in selected cases, digital subtracted angiography. I think probably the only current use of DSA in patients who have carotid disease on ultrasound or suspected to have it, but they are unable to tolerate, for example, large amount of contrast in CT angiography or MRA, and therefore they go for DSA with the intention for treatment if the carotid disease is confirmed. However, most of the time we rely on non-invasive imaging with CTA, which evaluate not only the lumen, but the wall and the plaque, and could give a good assessment of the arch for access consideration in cases of stenting. MR angiography is limited by availability and susceptibility to motion artifact, and it may overestimate the degree of stenosis. And finally, Doppler ultrasound, which could be useful in cases when there is severe calcification that renders the CT angiography hard to evaluate. However, it is operator dependent, and as a sole modality, I wouldn't advise it for the workup of patient with stroke, since it doesn't evaluate the intracranial vasculature. A Doppler, a transcranial Doppler, I mentioned it in stratification of patient with carotid occlusion, and it can also be good for stratifying the risk of patient with SINC, non-stenotic carotid disease, to look for high intensity signals, as we can see here. Current treatment options for symptomatic severe carotid disease, we have two revascularization options in addition to maximum medical treatment. And the maximum medical treatment in the current guideline include antiplatelet therapy, preferably dual antiplatelet therapy in the short term, lipid-lowering agent, as well as treatment of high blood pressure and diabetes. For the lipid-lowering agent, the current cutoff recommended for patients with severe carotid disease is less than 70 milligram per deciliter, which is about 1.8 millimole per liter. And that has been shown not only to halt the progression of atherosclerosis, but aiming for aggressive treatment of LDL below 70 has been shown to result in reduction of the intima media thickness, as we can see here in this study, where over time patient with more aggressive LDL target had in the long term smaller carotid plaques. Medical treatment has improved over the years, and as we can see here in the this graph, that compared patients who underwent revascularization in earlier carotid trials like ECST, NACIT, and the French VIA 309, compared to most recent or more recent trial, including CREST, we can see that the risk of recurrent stroke in patients waiting for revascularization in these studies has substantially dropped from about 4% to going down to below 2%. And that indicates that the aggressive medical treatment does reduce the risk, and it is a valid option, especially if patient cannot have either stenting or endotrechtomy. That also include the risk of recurrent of stroke in patients with asymptomatic carotid disease. In the past, this risk was quoted to about 3 to 3.5% per year, while in more recent studies, the risk is less than 0.5% per year. And therefore, patients with asymptomatic carotid disease, in the most part, could be managed medically, while in selected population, revascularization can be considered. For patients undergoing revascularization, current guidelines support both endotrechtomy as stenting by operators with established perioperative stroke and mortality rate less than 6% in those patient population. Carotid stenting is a less invasive procedure that can be done under conscious sedation, starting by crossing the lesion with the distal protection device, followed by angioplasty and then stenting, while endotrechtomy is done under GA when the artery is exposed, the plaque is dissected after clapping and then removed, and the artery is sutured back. A recent updated pooled analysis of individual patient data from a number of randomized controlled trials showed the long-term durability and comparable outcome in patients undergoing angioplasty and stenting. While the risk seems to be relatively small, the composite risk of stroke or death within about 4 months from randomization seemed to favor endotrechtomy in comparison to stenting, in particular due to high risk of minor stroke in the population undergoing stenting. In the long term, post-procedure ipsilateral stroke, the risk seems to be more or less comparable over time. when we look at the subgroup analysis, almost all of them seems to favor endarterectomy, and therefore my advice and the current guidelines support endarterectomy as the first line option, and patients who cannot undergo endarterectomy would be considered for stenting. Which patients are considered high risk for endarterectomy? Those who cannot tolerate general anesthetic due to heart conditions, symptomatic coronary artery disease, or severe COPD, or those who have anatomical challenges that make endarterectomy of high risk, such as restenosis after endarterectomy, contralateral carotid occlusion, radiation-induced carotid stenosis, limited cervical spine mobility, difficult access due to a high bifurcation of the carotid artery, and patient with isolated circulation, meaning that the carotid artery intracranially there is no ipsilateral posterior communicating artery, and there is no anterior communicating artery. And those patients in general, even with stenting, they are high risk for reperfusion hemorrhages, but with endarterectomy, which require clapping of the carotid artery, this could pose higher risk in comparison to stenting. Patients who are considered high risk for stenting are those who cannot have contrast due to renal failure or allergy, patients who are unable to lay flat and thus require GA or intubation, and patients with history of active malignancy that cause a coagulopathy with a stent in place, and those who are unable to take dual antiplatelet therapy. Anatomical factor, tortuous anatomy, although nowadays that is less and less an issue. If we cannot access the carotid using transfemoral access, we can go transradial access. Patient with heavily calcified plaque have a high risk of restenosis with stenting, although this again is a relative risk or a relative contraindication. Presence of a carotid thrombus, and usually we wait, start those patients on anticoagulation and wait before we undergo stenting or even endarterectomy. And nowadays, a third option is increasingly used, especially among vascular surgeons, is the transcarotid artery revascularization, TCAR, where patients are kind of put on supine in a hybrid operative setting, and they undergo under local anesthesia an incision at the neck. The carotid artery is exposed, limited by insertion of the special device that reroute the blood flow from the carotid going down to the femoral artery, to the femoral vein, sorry, which allows this flow reversal, decreases the risk of ipsilateral embolization during carotid stenting. And so basically, once the flow is reversed, a stent is advanced and deployed without or with minimal risk of embolization to the stent. And current studies, non-randomized nonetheless, have shown significantly low risk of ipsilateral stroke post these procedures. But current guidelines still that indicate that TCAR for prevention of recurrent stroke remains uncertain, and more high quality data is required. With that, I've kind of covered, hopefully, large aspects of the carotid artery disease, the classification and emerging condition or entities that are being increasingly recognized and described, and finally touch on the important aspect of secondary prevention patient with carotid artery disease. Thank you very much for listening. I'll be happy to take any questions. Thank you.